Hello, good morning and welcome here live on the EAO channel where we're broadcasting from the 2019 Congress in Lisbon. And this morning we're about to take you into the auditorium to learn more about the session How to Treat Implantitis. And if you're just joining us because you're watching this in recording and you've Googled that term, How to Treat Peri-implantitis, I should make note to you that this is a scientific congress where implant dentists from all over the world come together to learn the latest insights in their field of profession. And I'm glad I'm joined this morning by a professional who knows all about that, Kasia Kuzawaska from Birmingham in the UK. Good morning.
Good morning, everyone.
Kasia, you're my co-host this morning. You will guide me and our viewers first in the first 30 minutes towards the session, and then afterwards, when the speakers are done, they come down here in the studio and we'll have an interactive Q&A and debrief with them. Let's start with the topic of peri-implantitis. Let's explore that a bit. What is your relation to that topic?
So first of all, I will explain in short terms what is peri-implantitis for all our audience. So it's an inflammatory disease affecting soft and hard tissue around the implants. And as we saw during the last years, the number of implants we use every day in our practice is increasing. So the risk associated with inflammation is also increasing, and the prevalence at the moment was rated to be 22% based on one of the our speaker today, Jan Derks. So we'll definitely hear about more his studies and his relation to peri-implantitis and his discovery as well.
Okay, so let's slowly dissect this a bit. You say it's an inflammation disease. Is it the same that any inflammation around my implants is peri-implantitis, or is it something more complex than that?
So it's rather complex and multifactorial disease, and we don't have full understanding what is happening around implants. So therefore we are still trying to find the right therapy for peri-implantitis, and of course we will hear a lot about it. So my relation is more prevention of peri-implantitis. I think most of us agree that it's the best treatment. My field is working on a molecular level and understanding how actually the bacteria and biofilm, that it's very complex, cause the inflammation through the infection process, and why the mechanism is important to understand how to treat the peri-implantitis in future.
Yeah, you're doing some very exciting research in that. Maybe if we have time, we follow up on that. Let me invite our viewers as well. If you're watching us live, you can use the feature of our live chat to send in any questions you have. So if anywhere during my chat with Kasia you have a question, or perhaps anywhere during the 90-minute session in the auditorium you have a question, send in via the live chat and I will relay those questions to the speakers who will join us here in the studio right after the session. By the way, if you're watching this, we'd love to know who you are and where you're watching from, so why not give us a shout out right now. Now, Kasia, you say the word prevalence, so the occurrence of peri-implantitis is quite common. You say up to 22%.
Yes.
So it's basically 1/5 of the people who receive an implant might also develop peri-implantitis.
And it's also related to number of factors as well, like systemic diseases, smoking, a failure of previous implants, other immunosuppressants treatment. So we need to take into consideration all the factors and select the patient for implant treatment carefully. And we are stressing it during the Congress a lot because we think that it's related to later on the risk of peri-implantitis as well. That's very important, the treatment planning. And later on, recalls of our patients. That's very challenging, but it's very important from the follow-up point of view and prevention of the peri-implantitis later in the stage, to have the strict regime for the patients, to let them know that this is the foreign body, it's not the tooth, the dental implant.
The implant is the foreign body,
Yes.
Yeah, basically that's You already mentioned we don't exactly yet fully understand how it works, but what we do know, you introduce a foreign body in your human body and something happens that the disease exists. Before we go into the root causes, what is the effect? What happens to me or my mouth if I have peri-implantitis? What kind of symptoms will I develop?
So first of all, there is a redness, erythema, swelling, and we call it mucositis. So it's an inflammation of soft tissue around the dental implant.
Yeah. Painful, probably?
It may be painful,
Yeah.
and if it's progressing farther, there is suppuration of the pus that is notable, and also in that point we really need to do something about it, because then later on it will progress to peri-implantitis. So there are two stages, and we need to really understand them, and all the treatment that we will hear today will prevent from further development of peri-implantitis and in the end failure of the implant, what we don't want to see in the clinic.
Yeah, because it starts with maybe with an inflammation. When it develops to peri-implantitis, what happens then? What are the symptoms? What does it do in my mouth?
So pain, and also the most important, you notice when you have the restoration of on the implant, it's mobile, because you lose the bone around the implant. Because
that's the key, right? The bone recedes.
Yes, and then you experience that the denture or the crown, it's moving. So also when you in the normal daily function of your mouth, with when you talk, when you eat, you experience pain and discomfort. That definitely it's a sign of inflammation, and that you should contact your dentist.
Exactly. So the soft tissue will recede. In the end, the bone will be lost as well, and then we lose the stability of the implant. To my understanding, what is the speed? What is the timing of the development of peri-implantitis? Do we know anything about that?
There are two stages up to 1 year. That's a rapid progression of the inflammation, and then the late stage, when from 1 year to up to 10 years or even higher. So we by the book it's divided. However, it's important that we, after implant placement, we see the patient. Well, there are in literature there are different time points where we should recall the patients. In my hospital, we usually see the patient after 3 months, 6 months, 9 and 12, and after 1 year, that we know that it's the periodontal status, the hygiene status, it's stable. Then we can reduce the frequency. Exactly.
And how easy can you spot or determine peri-implantitis? Is it basically any inflammation around my implants is probably peri-implantitis, or is there also an innocent form of just aroused soft tissue and it's not yet that far?
First you see the redness and some discomfort, because when the patient clean around the implants, they experience bleeding and also pain, and then at that point they should start to think, is it something that is not right? Of course, there are patients that they have the problem with hygiene and bleeding around the teeth as well. So don't stress so much.
Exactly.
Just contact your dentist, and then this has to be investigated. But the redness and swelling, that's the first sign for inflammation.
Yeah, to further investigate. Now, you say we don't exactly understand this yet. It's a topic highly researched in science, and we're moving along every year. So I invite you to keep coming back to the EAO channel and come back to the EAO Congresses to learn about the latest developments in peri-implantitis. Let's zoom in a little bit on the stuff we do know, because you already briefly mentioned there's some patient indications that implant dentists should be aware of and should be careful about when choosing an implant, right? Let's go through these. You say systemic diseases. What kind of diseases do we know are prone to cause peri-implantitis?
So definitely diabetes.
Yeah. Is it that predictive that if you are a diabetes patient, you should not go for implants? Is it that black and white or not yet?
No, if it's controlled diabetes, of course, we consider those patients for a dental implant treatment. However, at the place that I work in University of Birmingham at the hospital, we have a very good relation with general practitioners and specialists if necessary. So we do the screening for the patients and we make sure that they get the right therapy before their implant treatment. So if the diabetes is controlled, systemic disease, fine. They also need to receive the hygiene treatment and all the instruction before the consideration even for implant treatment. So we need to know that the periodontal status is it's stable as well. That's crucial because based on literature we know also that the patients with periodontitis, they are more prone to have also peri-implantitis in future.
Exactly.
Cardiovascular diseases is a second a disease that we consider as a risk factor. Also immunocompromised patients. Yeah. That's also a challenging group of patients, and elder patients as well with dementia. Because of the ability to clean.
Exactly, so that's not so much about what the body is able or not able to do, but about taking the extra care and cleaning exercises for the implant.
So our patients are, some of them were elder and also poorly, so we need to carefully consider if it's really the best treatment for them. Maybe the conservative treatment with denture, removable denture, it's something what we should advise and consider. So not always dental implants are the best choice.
Exactly, because it's not as easy as just getting an implant and brushing your teeth. It's quite high maintenance.
Yes, it is high maintenance. We need to remember about it. There are a number of methods that we use for hygiene for patients, and also it takes time for them to learn. The education, it's a very important factor, and also based on literature we know that it is related to the peri-implantitis, later on to develop peri-implantitis.
Interesting. So it's first of all do a good analysis of your patient, determine these risk factors up front. A second risk factor you mentioned is smoking. What do we know about the effect of smoking and the development of peri-implantitis?
So definitely there is a relation between smoking and peri-implantitis. So smoking, it's increasing the risk of inflammation in general in your body. It has a number of other effects on our body, like there is a risk of cancer, we know about it. So our body, it's not having the same response to the inflammation, to infection going on in our body. Therefore, of course, our cells are downregulated to the inflammation. Therefore, we can't have the same regeneration process as a normal and healthy body.
Exactly. It's interesting. If you're just joining us, we are live here on the EAO channel from the 2019 Congress here in Lisbon. And I see people are starting to make use of the fact that we are live and using the live chat function to send in questions. So let me take a question which is very related to the topic of smoking. The name is AJ. Well, it's Axel Junila from Finland. Axel, good morning. Glad you're with us. And he's asking, how should we act with patient selection when talking about nicotine use of the patient? And let me stretch that question a bit. Is smoking a contraindication for an implant?
It is one of the contraindications based on the literature. We consider smokers for implant treatment when they quit smoking. So.
And that should be a strict prerequisite?
At least in least in the field that I'm working, in the area I'm working, we have very strict restriction criteria for selection of the patients for implant treatment, because we can't afford failure. So that's one of the factors that we always consider smoking. So we need to have a documented that the patient quit smoking.
They need to sign off for that.
Yes, and also, of course, there is a consent form that we always sign, and also we inform the patient that if that's the main risk for peri-implantitis, and we write always on the consent form that's the risk failure of the implant. So the patient needs to understand, not only sign the papers, but also understand, therefore, it's important that you consider the leaflets in your clinic for the patients. Make sure that they know and they understand what we are talking about, because when you have the consultation, they are very stressed, they very often they forget.
It's an intimidating environment, right?
Yes, yeah. And there are different patients, of course. We need to remember, for them, maybe for us it's daily life, but for them it's very often a change of their life if they have implant because of the different experience they had previously. So suddenly they know that they can smile again. However, they forget
not
about
the
not with the cigarette, exactly.
Yeah.
So of course it's a lot of patient factors that we need to consider,
yeah.
And also we stress a lot about the communication between the dentist and the patient. Because without the communication and understanding, we can't succeed with our treatment.
Exactly. Now you you mentioned it's a contraindication where I work. You work in the UK. We are in a very international context, the European Association for Osseointegration. We have visitors from all over the world. Are you aware of any regional or geographical differences? Is the UK very strict? How is this across Europe or the world?
I think, of course, there are differences, and we know about it. And we are here to show the scientific evidence, yeah. For implant treatment, and also prevention of the diseases. I will not point any of the countries.
No. Let's stay with the fact there's countries where smoking is not a contraindication.
It is.
That is the conclusion.
So, and they have successful treatment.
Yeah, because we're still talking about the risk factor, right? It's
course.
not a one-on-one relation. If you smoke, you develop
the
peri-implantitis.
same with systematic diseases. You need, every patient is different, and you need to take every case separate. So don't generalize. Try to understand every step of the treatment.
Yeah, so if you're just joining us, we are live at the EAO Congress in Lisbon. We're having a preview to a session that is titled How to Treat Peri-Implantitis, which is chaired by Professor Schwarz and Aušra Ramanauskaité from Lithuania. And we will have two speakers on stage, Ignacio Sanchez from Madrid in Spain, who will give us an overview of the current approaches in peri-implantitis. And the second speaker will be Derks. He's from Sweden, and he will talk about regenerative approaches for peri-implantitis. And we'll briefly look forward to that soon, but we're still kind of discovering and uncovering the field of what we know and what we don't know, together with my co-host, Kaja Guzawaskas. Now, Kaja, you mentioned a few risk factors that we know about. We've covered two, systemic diseases, smoking. You mentioned the third one.
Periodontitis, previous periodontitis in the patient,
yeah.
And I touch a bit the topic that we need to establish the periodontal status of the patients before, and of course if they have bleeding on probing and inflammation in general around the teeth.
Yeah. Before we even
consider,
yeah.
Then those patients, they will definitely be a risk group for later on peri-implantitis. So before we consider the treatment, we should definitely establish the stable, at least 1 year follow-up of the patient, that the progression of bone.
You say 1 year before you even consider implants.
Yes.
So we should really understand our patients very well. Wow. So how does it work? So I come to your practice, I say I need an implant. Maybe, I don't know if I make that call, but say I've been on Google, I've been watching EAO channel, and I say I want an implant. You first tell me, well, Gerrit, I'm going to monitor you for 1 year before I even consider.
Well, this is again the practice in our hospital.
Yes,
and it's
science-based. This is what science says you should do.
And also we know, well, our recall system is of course different in the private practice. So you may consider the treatment earlier if you see the patient, but however, inflammation and all the regeneration process takes time. You will not stop the chronic periodontitis in 3 months. It takes time, and also the patient needs to learn how to clean and take care of yours. And very often they have other diseases, so they have to go to the general practitioner to get the medications, and then in the combination of the medical care and our care, dental care, we can establish the statement, okay, well, now we are ready, we know that now it's safe to place the implants.
Exactly, exactly. It's good to understand, because every now and then in these congresses we learn about these cases of, I had this patient and she needed to get ready for her marriage and the best pictures of her life, and I had 6 months, but actually this is quite a lengthy process and approach, right?
Yes.
Yeah. It's beautiful, we are live, and you are taking opportunity of the fact that we're live. So we're seeing live questions coming in, and please keep doing that throughout the next 2 hours, because our speakers on stage will be right here in the studio after they finish their talks in the auditorium, and they can take as many questions as they want. And well, Kasia, I have a few. First one that comes in is from Sunyoung Ma. Sunyoung, let's see if you, she or he doesn't tell us where she's from, but the question is there any difference in the risk of implant failure or peri-implantitis when it comes to vaping? And let's start with the end of the question. Vaping is the electrical smoking, right? Do we know anything about that? Or is smoking just smoking?
There is very little research about it.
This is quite a new development.
It's very new, and I'm very interested in this topic, because very often patients are coming to me, oh, if I quit the smoking, can I change it to electric?
Yeah.
And I always tell them there is not enough evidence, and because my research is concentrated on nanotechnology, and we know that nanoparticles may cause inflammation as well, and we don't know how. And
it basically goes back to the fact that we do not fully understand this disease yet, right?
No.
So we don't know. We see smoking as a risk factor, but which part of the smoking? Is it the nicotine? Is it the other elements? Yeah.
We really don't know, and unfortunately today I can't tell if it's contraindication or not, and I'm looking forward for more science, and hopefully I will have a chance to work also on this topic in future.
Exactly, yeah, interesting question, thank you very much. And if you're watching as a young scientist and you're wondering what kind of research area you would like to go into, maybe this could be a topic of your next research. I have another question. It's from Jiris B. Viswanathan. I think I should say good afternoon to you based on your name. I think you're in the Far East. And the question is, the occlusion increase in the crestal bone the crestal bone loss as read from journal. So how is it related to implantitis? So I think this is someone writing in. So what do we know about the increase in the crestal bone loss and peri-implantitis?
I think the question is more related to the loading of the implant later on. And we know that when we have the osseointegrated implant, we can load it with the denture or a crown or bridge. And I think he's asking if there is a relation between the loading force and the crestal bone, and then this may affect peri-implantitis. Well, it's there are a number of factors. We talk about peri-implantitis in general. So there are a number of factors that may influence peri-implantitis, like surface of the dental implants. Later on, abutments. Mm-hmm. So nowadays we tried to use a smooth abutments in order to prevent from any bacteria grow. Yeah. And we know that the smooth abutments will not attract the biofilm and the bacteria in grow as much as the rough. And
those we've been using in the past quite a lot, right? Yes. So if you have older implants, you probably have a rough surface abutment.
Yes, used to. It was in the 80s, and then a large number of discovery was done by a group Albertson and Wennerberg in Sweden, where they showed that the moderate rough surface is recommended for nowadays for the success of osseointegration. Coming back to the loading of the implants. Of course, we need to consider the good aesthetic and the right restoration, because if we have overhanging of the crown of the denture, the patient have problems with cleaning. And of course, in this situation, there is no question they will have bacteria ingrowth in this area because they can't clean. So I think you need to work in the team with the restorative colleagues to maintain the restoration and make sure that it's in the right occlusion and with physiological zone as well.
Exactly. Well, thank you. In the meantime, we've learned that Sun-Young Ma is actually joining us from New Zealand, so I think that's a good afternoon to you as well. Thanks for sharing that with us, and great that you are participating so actively. We've been previewing the session that is about to start on stage about how to treat peri-implantitis. Now, just before we go into the auditorium, Ignacio Sanchez will give us an overview of the current approaches to peri-implantitis, and then Jan Derks will zoom into the regenerative approaches, because we've already learned from you, peri-implantitis, we will lose soft tissue, we will lose bone. Regenerative approaches, what can we expect from Jan there?
So Jan will talk about regenerative approach, as you mentioned. Because we are losing the bone, so we just need to regenerate the bone.
And that's possible, yeah, we can somehow modify.
With using bone substitute materials, membranes, and I don't know if you will talk about PRF as well. That's a quite hot topic because of the natural aspect, the biological aspect of PRF. I think we'll learn more about different techniques, different materials, and also assessment of the patient when actually use the regenerative therapy.
Yeah, exactly. So it's an extensive session. We learn where we are in the field, the current approaches, and we learn what we can do. Because just a quick outlook, if I'm diagnosed with peri-implantitis, what is the worst outcome that can happen?
Failure of the implant.
Which means?
Which means that you lose the bone and it needs to be regenerated later on to have other implant or not have at all implant because the bone is too weak and you need to have the conservative treatment with the bridge or with denture. Yes.
So let's see if there's any way we can prevent that. If you've just joined us, we are live here from the EAO Congress 2019 in Lisbon, and we're about to take you upstairs into the auditorium where you will be following the session How to Treat Implantitis, which is chaired by Schwarz and Aušra Ramanauskaité. You will see two speakers on stage. First up, Ignacio Sanchez, who will talk about the current approaches in peri-implantitis, and next up, Jan Derks from Gothenburg in Sweden, who will talk about the regenerative approaches. This session will last for 90 minutes, but the good news is, after it's over, both speakers come right here in the studio with me and Kaisha, and they will take any questions that you have. So keep sending in your questions, because we will take them right here in the studio. We will follow the session together, we'll briefly summarize, and we hope that you will be as active as Sun-Young Ma has been, and Girish has been from all over the world. So please keep them sending in. We'll collect them as long as they come. So I think the room is getting ready upstairs. We hope you're able to follow, and we look forward to see you back in about 90 minutes here in the studio.
Hello, good morning, everybody, dear colleagues and friends. It's a great pleasure to open this session, to see so many people in this early morning here in the room. So it's a great pleasure having you all together. It's my great privilege and honor to co-chair this session with Aušra Ramanauskaité.
Good morning, dear colleagues. For me, it's indeed a great privilege to be a part of a session.
And we both have, of course, a tight schedule. We have a session title that just by reading the words is so simple, how to treat peri-implantitis. But as you all know, the clinical need and of course the clinical challenge behind this simple question is really ambiguous. So in preparation of this session, more than 1.5 years ago, we have tried to identify and select the most appropriate experts, so both clinical and scientific experts in the field, and I'm more than happy to have both Ignacio Sanz and Derks today on stage. So the whole setup will be 2 presentations, about 35 minutes, and hopefully we will have about 20 minutes at the end for an intensive interactive discussion. So please keep in mind this session will be live broadcasted on the EAO YouTube channel, and please download the app to raise questions to the speakers and to the whole topic. So Aušra, maybe we jump into the topic. We start with the first presenter.
So, dear colleagues, let me introduce you our first speaker, Ignacio Sanchez, who will present us the current approaches for peri-implantitis treatment. Ignacio is a specialist in periodontology. Currently, he is an associate professor at University Complutense of Madrid. Also, Ignacio is a member of EAO Junior Committee. He's a member of Executive Board of Spanish Society of Periodontology. And here I could continue and continue. Please welcome Ignacio on the stage.
Dear friends, dear colleagues, it's a great honor to be here today on the stage with such good friends and colleagues, Aušra, Frank, Jan. And therefore, for this reason, I would like to thank the scientific committee, their great opportunity. The main goal in the treatment of peri-implant diseases is going to treat bacterial infection and thus to arrest inflammation. And in the case we have peri-implantitis, we are also aiming to treat the osseous defects. And to achieve these goals, we need to take into consideration several factors before initiating our treatment. First of all, how is plaque control? Not only by the patient, but also by the dentist or by the hygienist. We need to assert cleansability in order to be predictable in the long term. Another thing that we need to think about is how we are expecting to reduce probing depth. Also, something that worries us a lot is how we are decontaminate the implant surface. And last but not least, we need to analyze if bone reconstruction is feasible or not. And to assess treatment success, traditionally, we have evaluated the changes on clinical outcomes, how we have reduced bleeding on probing depth, plaque. But we need to realize that some years ago, it was recommended that we need to look for a composite outcome, and this is called disease resolution. And to be successful, we need to achieve at the same time the absence of bleeding on probing and suppuration, a non-increased probing depth. This means a probing depth not greater than 5 millimeters, and no additional bone loss. And we know that if left untreated, peri-implantitis is going to progress rapidly, and we may end up with a vast variety of peri-implant defects. Some years ago, one classification was proposed by our chair, by Frank Schwarz, that basically distribute defects on 2 types, class 1 and class 2 defects. Class 1 are vertical defects, intrabony defects, and this classification was based on epidemiological data. And it was shown that around 50% of the defects are going to be also associated to adhesions of the buccal and or lingual plate. On the contrary, class 2 defects are horizontal defects, supracrestal defects, and it's remarkable that we see that 80% of these defects are also going to be associated to intra-bony defects. This means that around 80% of the defects are going to be combined. And classifications are good because they can guide us, or they can help us in the decision-making process of which type of procedure should we use. And of course, the ones that belong to the field of peri-implantitis know that the non-surgical treatment of peri-implantitis is it's very, very, very effective, and it's going to control more than 80% of the cases. And for this reason, we need to wonder if the non-surgical treatment of peri-implantitis is also effective. And when we look to the literature, we can observe that 6 systematic reviews have been published with conflicting results and showing limited predictability. And I would like to focus on the systematic review by Fayon and co-workers, in which they select randomized controlled trials and they perform a network meta-analysis. And it was observed that although we use new technologies, that despite using adjunctive therapies, the added benefit as compared to conventional debridement was limited. And the best results showed, although non-significant, a weight mean effect of less than 0.5 millimeters. So it seems that non-surgical treatment of peri-implantitis is not as effective as we would like and as we have seen when treating periodontitis. Today, different protocols have been proposed and published, and these protocols use more aggressive decontamination methods, combining different also decontamination tools, and in many cases using systemic antibiotics. These procedures have shown success rates between 40 and 50%, so results are not that bad. However, we need to take into consideration that this data comes from retrospective case series. So we cannot say that the good effect is due to the antibiotic, is due to the combination of, for example, a curettage of the granulation tissue plus air polishing. So these are just proof of principles that need to be confirmed with randomized controlled trials. Nevertheless, we're always going to start with non-surgical therapy. Then we will monitor our implants. And if we have been successful, if we have achieved disease resolution, then we can place the patient in a maintenance protocol. If not, we will do surgery. And among surgical procedures, you can see that we can do an access approach, a resective approach, or a reconstructive approach. And some years ago, together with Professor Schwarz, we proposed this decision-making tree. You need to take into consideration that this decision-making tree is based on observational studies and not in randomized controlled trials, so it should be interpreted with caution. But what more or less we propose then is that if the initial bone loss is very extensive, we're saying more than 2/3 of the implant length, we may consider to extract the implant. Why? Because it has been shown in the literature that in the cases that the initial bone loss is too high, the chances to achieve disease resolution are very low. On the contrary, if bone loss is not that big, we may consider to do surgery if the non-surgical treatment has been ineffective. And we're going to use, or we may use, defect configuration in order to select the type of procedure. We don't have doubts that when we have a pure intra-bony defect, we're going to go for reconstruction. If we have a pure horizontal defect, we will go for access flaps or resective flaps. And we may have doubts on what to do when we have combined defects. In these cases, I'm proposing, based on clinical experience, to use a combined approach, as we will see later on. An access flap consists on opening a flap, eliminating the granulation tissue, decontaminating the implant surface and suturing back the flaps in the same initial position. It's going to be the main choice when we're dealing with a peri-implant defect in the anterior area and reconstructive therapy is not feasible, and also when we're dealing with posterior implants in which we are not going to modify the architecture of the soft and or hard tissues. The long-term results of this mode of therapy have been published by the group of Lisa Mayfield. This is a prospective case series that included 24 patients and 36 implants diagnosed with peri-implantitis. Patients received access flap. Implants were decontaminated using titanium curettes. Moreover, patients received a cocktail of systemic antibiotics, including amoxicillin plus metronidazole, and patients were included in a maintenance program every 6 months. Patients were followed for 5 years, and disease resolution was the main outcome in this study. And it was observed that 5 years later, 63% of the patients achieved disease resolution. 17% of the patients presented at least one implant failure. 17% were lost to follow-up, and 3% presented disease recurrence. And they looked to which factors could have an impact on failure at 5 years. And it was observed that there was a tendency for the presence of plaque and bleeding on probing at the 3-year evaluation to increase the risk of presenting failure of the treatment with odds ratio between 3.5 and 4.2. Also, the group from Göteborg has published this retrospective case series that include 50 patients and 95 implants diagnosed with peri-implantitis. At the time of surgery, implants have been infected with a mean time of 7.5 years, and patients again received an access flap approach using titanium curettes. Among this pool of patients, 72% received systemic antibiotics, and we need to highlight that around 50% of the implants had a machined surface. Patients were followed for a mean time of 4.5 years, and patients were placed in supportive therapy every 4 months. It was observed that the overall success rate was really low, 30% at the patient level, 35% at the implant level, and it was observed that disease resolution was 3 times greater, 2 at the implant level, in patients carrying implants with a machined surface as compared to rough surfaces. I would like to illustrate this technique with one first case. This was a non-periodontal patient that referred to me that the gum was throwing out his implant. At the visual inspection, we can confirm that there is some marked recession, there is a lack of keratinized mucosa, and there are some clinical signs of visual inflammation. However, if we had not probed this implant, we could never say that this was the situation. Very deep pockets, up to 8 millimeters, bleeding on probing, and a clear white horizontal defect. Since we didn't have any amount of keratinized mucosa to be removed or to be resected, we went for intracircular incision approach, access flap approach. This time we could remove, this was a screw prosthesis. This is going to facilitate a lot the soft tissue management and the whole surgery. We raise the flap, we eliminate the granulation tissue, and this time we use an erbium gel laser to decontaminate the implant surface. We didn't do any bone surgery, and look to this situation. This is commonly seen. Same patient, same site, same bacteria. The tooth has maintained the attachment, the implant has lost it. And this is going to guide the position in the future of where is the mucosa going to be at the end of surgery. So we need to assume that at this level we may end up with a residual pocket. And this is very commonly seen when treating peri-implantitis close to teeth. We suture the flaps. This was the 1-week healing. If the aesthetic and the functional requirements allow me, I avoid placing the prosthesis during this first week or 2 weeks. 5 years later, when we look to the changes, there is a clear improvement in terms of visual inspection. Of course, there is an increase in recession, and this is very important because we need to advise in advance to our patients that after treatment, recession is going to occur. And recession around an implant implies to have a gray portion outside. It's not the same as having a recession in a root. 5 years later, bone levels remain stable. And from the clinical point of view, we didn't have any pocket greater than 5 millimeters or bleeding or probing. So we can say that this is a case in which we have achieved disease resolution. Let's take a look to another case. This was a smoker patient, a periodontal patient, that abandoned supportive therapy, and she came back 3 years later. And during our checkup, we saw that there was a pocket depth of 7 millimeters, suppuration, bleeding and probing. We took an X-ray, and we can see how there was a clear bone loss. We raised a flap, and this was the situation. We cannot reconstruct anything of this type of defect. It's a pure horizontal defect. So this time we went just for cleaning the implant. We used Erbium jack, ultrasounds, and peroxide, and we sutured back the flaps. And 2 years later, it was a complete failure. We still had clear signs of inflammation. We still have deep probing depth and ongoing bone loss. And moreover, we decided to choose this type of approach in order to not creating a very big problem on the aesthetic area. However, as you can see, even after doing an access flap, the amount of recession was big. For this purpose, we may consider to use combined therapies by using connective tissue grafts to arrest or to compensate recession, as it was demonstrated by Professor Schwarz. Another type of surgery is resective surgery. In resective surgery, we are going to modify the architecture of the soft and/or hard tissues in order to achieve a greater probing depth reduction and to improve hygiene measures. The long-term results of this mode of therapy were published by the group of Serino. Patients received resective surgery, and then they were placed in a maintenance therapy, very strict maintenance therapy, in which the prostheses were removed, and they used ultrasounds and chlorhexidine irrigation. Baseline is 6 months after surgery, and here you can see the results. In blue, you have implants that from the beginning were healthy in this pool of patients that were treated for peri-implantitis, and we can observe that with good maintenance, implants can remain healthy, and only one of the non-treated implants increased its probing depth. On green, we have implants that after being treated of peri-implantitis did not have residual pockets or bleeding on probing. And they observed that if we achieved a pocket eradication, results can be very stable. And they were those implants presenting residual pockets and bleeding on probing, the ones that had higher chances of worsening over time. Indeed, 28% of these implants presenting residual pockets increased probing depth over time, and 13% presented attachment loss. Let me show one case. This was a periodontal patient, a heavy smoker, her periodontitis was quite good controlled. However, she was erratic with the plaque control. This is in a supportive therapy during maintenance, spontaneous bleeding. We probed, we observed probing depths up to 8 millimeters and a clear horizontal defect. This time we could not unscrew the prosthesis. This is going to difficultate a little bit the soft tissues management. We raised the flap, we did some scalloping in order to have a greater probing depth reduction, and you can see that this was an overhanging restoration. We tried to convince the patient that the best thing would be to change this prosthesis, but as many times occurs, the patient refused to do it. We decontaminate the implant surface with therapy jack laser. We did some osseous surgery in the interproximal spaces, in inter-implant spaces, and we apically sutured our flaps. This was the 1 week healing. At 6 months, you can appreciate that the patient had a lot of troubles to clean this prosthesis, to maintain free of plaque this situation. And this is an interesting case because we have the 10 years follow-up. And at 10 years, of course, there was an improvement. We have been able to maintain the bone, but we have not been able to achieve disease resolution because this patient is still presenting inflammation around the peri-implant tissues. Let's take a look to a different case. This was also a perio patient, smoker, that abandoned supportive therapy for a period of 5 years, and then she came back with a peri-implant infection in this posterior sextant. We did non-surgical treatment of peri-implantitis that was not effective on arresting active infection, as you can observe by the pocket depths and the presence of bleeding on probing and suppuration. And this time, we decided to go for resective surgery. We did some scalloping, distal wedge. The amount of keratinized mucosa allowed us to go for this procedure. We raised the flap, and you can see the aberrant bone that has remained after infection. So we went for extensive osseous surgery. We apically sutured the flaps, and we have the 4 years follow-up with a clear improvement, with the absence of residual pockets or bleeding or probing, and with an improvement in terms of the bone levels, with a clear situation showing disease resolution. However, we have seen that the results are quite heterogeneous. So different protocols have been proposed to improve predictability. One of these protocols is implantoplasty. Implantoplasty consists on eliminating the rough surface and the implant threads by grinding and smoothing the implant surface in order to facilitate plaque control to the patient and also to the dentist, because we are going to have a submucosal portion of the implant. I would like to illustrate the technique with this case. This was a perio patient, very well controlled, very well controlling also his self-performed plaque. However, he presented a peri-implant infection with pocket depth up to 8 millimeters, a small fistula. And we have to remark that this implant was previously treated with a reconstructive procedure that failed. For this reason, this time we decided to go for a more resective approach. We did some scalloping, we raised a flap, we did our implantoplasty procedure, we apically sutured back the flaps. This was the 1 week healing, very nice healing. 3 years later, disease resolution, no inflammation, and the maintenance of the bone levels. Again, we need to advise the patient that after this type of procedures, recession is going to occur and that a great portion of the implant may be visible. The long-term results, 3 years, maybe it's not too long, okay, have been published in this randomized control trial by Romeo, in which implants receive resective surgery with or without implantoplasty. And it was shown that at 3 years, patients that receive implantoplasty had significant less bleeding on probing, less probing depth, and less probing attachment level. And moreover, patients receiving implantoplasty had stable bone levels, no bone level change a lot, whereas patients not receiving implantoplasty experienced 1.5 millimeters of apical displacement of the bone. Very recently, this retrospective study by Bianchini has also been published, in which 2 to 6 years after the resective procedure plus implantoplasty, 83% of the patients achieved disease resolution, and 13% of the implants were lost, mainly on the first stages of healing. However, it's not gold, everything shining, and we need to realize that when doing implantoplasty, we may have an effect on the resistance to fractures, since we are reducing the amount of titanium, especially on the weak area that is the connection. In this in vitro study, 3 types of connection, external, internal, and tapered, were evaluated. Implants received implantoplasty on the first 5 millimeters, and it was observed that the resistance to fracture was reduced around 30–35%. And special attention needs to be placed when we do implantoplasty in narrower implants. Moreover, when doing implantoplasty, a lot of titanium powder is going to be released, and even after trying to properly eliminate, a lot of remains are going to be sticked in the soft tissue, and we still today don't know which is going to be the impact of this titanium powder in the long term. Moreover, implantoplasty is not always easy. Sometimes it's almost impossible to do it right, especially when we cannot de-cement the prosthesis or when we have the implants too close to the floor of the mouth. Okay, so we need to understand that there are technical limitations. But placing everything in perspective, today with the in vitro studies, preclinical studies, and clinical studies, we cannot say that peri-implantitis, implantoplasty is associated to an increased risk of mechanical or biological complications in the short mid-term. Also, a combined approach was proposed by our chair, by Professor Frank Schwarz, in which we're going to combine implantoplasty and a reconstructive procedure. When are we going, or when can we use this mode of therapy? Especially when we have combined defects. This means that we are going to do implantoplasty in the supracrestal component and also on the buccal or lingual dehiscence, whereas we are going to reconstruct where we have intraosseous defect. This decision-making was based on previous studies in which it was observed that reconstruction in defects that have buccal dehiscences achieve worse results as compared to pure intrabony defects. This technique was proposed in this randomized control trial in which 2 different modes of the contamination were compared, and these were plastic curettes plus saline in comparison to Erbium Jack laser. And the long-term follow-up of this study, 7 years, showed that among the patients that finished this follow-up, these were 15, 79% achieved disease resolution, and 4 patients presented reinfection after 2 and 3 years. I would like to illustrate this technique with one case. This was the same patient in which we did a resective surgery with osseous surgery. That patient that abandoned supportive therapy for a period of 5 years. In this patient, after non-surgical treatment, we decided to place a cover screw in order to get a soft tissue coverage to go for a submerge approach. 6 weeks after non-surgical therapy, we reopened. You can see the type of defect in which we have a clear buccal dehiscence and an intrabony component of the palatal, some of the buccal, and also on the interproximal sides. We did the implantoplasty on this buccal dehiscence. We decontaminate the implant surface using ultrasounds and an air polishing system with erythritol. And then we reconstruct and we filled the defect with the peroxidized bovine bone mineral graft covered with a resorbable collagen membrane. We suture the flaps. Here you can see how we submerge the implants since we achieved the soft tissue coverage. And this was the 2 weeks healing with very nice healing. 6 months later, we went for a reopening, and we can observe the very nice clinical results that could be maintained for a period now of 3 years, okay? With the absence of residual pockets, with the absence of clinical signs of inflammation, and with an improvement in terms of the radiographic bone levels, a clear case of disease resolution. Another approach could be the use of antimicrobials, and I would like to focus on the 3 biggest studies comparing the use or not of antibiotics. In the first 2 ones, they use systemic antibiotics. In the last one, they have used a local antibiotic. In the first study from the group of Gothenburg, in which our next speaker took place, they studied the added benefit of using systemic amoxicillin together with a resective surgery in 100 patients as compared to the not use of the antibiotic. Patients were maintained every 3 months, and at 1 year, the overall success rate was low, was around 45%, but significantly was greater when they treated machined implants, 79% as compared to 34% for rough implants. And when they looked to the impact of giving or not antibiotics, there was an added benefit when using antibiotics together with the treatment of rough implants, but not with machined implants. However, in the long-term follow-up, this added benefit remain and start to dilute. We also have this randomized control trial by Hallström, the group of Stefan Rember, in which 40 patients were randomized to receive or not azithromycin. And 1 year later, it was observed that although disease resolution was slightly greater in the test than in the control group, these differences were non-significant. And the last study that has been recently published in the Journal of Dental Research from the group of Johnson has evaluated the impact of giving minocycline gel during surgery and during supportive therapy at 1 and 3 months, and they observed that when given this local antibiotic, disease resolution was almost double in the patients receiving it than on the patients receiving the placebo gel. Finally, we could think on modifying the quality and the quantity of the soft tissues. A few years ago, we performed this systematic review in which we demonstrate that procedures aimed to gain keratinized mucosa were associated to improvements in gingival index and in the bone levels. So for this reason, we need to ask ourselves if we should change the features of the soft tissues once there is peri-implantitis. And the amount of literature here is very scarce. This study from my friend Alberto Monge has very recently published, and they did resective surgery plus implantoplasty plus a free gingival graft. 14 patients were treated, and they were followed for a period of 1 year. And in 71% of these cases, they also did prosthetic modifications to assure and to improve cleansability. They observed that plaque levels, bleeding, unproving, and suppuration remained very low during the whole study period. Of course, that there was a gain in the keratinized mucosa, and that probing depth remained below 3 millimeters during the whole study. Moreover, disease resolution was high, 87% at the implant level, 80% at the patient level. Today, we are running this randomized controlled clinical trial in the University Complutense of Madrid, employing exactly the same procedure as the previous study, but we are randomizing the patients to receive free gingival grafts or a collagen matrix. This is an ongoing study, so far, since we have not included all the patients, I cannot present the clinical data, but I can show you this case that was presenting peri-implantitis at this implant. We did a combined flap. This means a full thickness flap in the most coronal portion in order to be able to do the implantoplasty, and then a split thickness flap in order to be able to anchor our matrix or our graft. We placed the matrix. This was the 2 weeks healing. Very nice 3 weeks healing, and we have the 6 months in which we have a very nice situation, a clinical improvement. Of course, there has been some shrinkage, but a clear case of disease resolution. Irrespectively of what we do, we still feel like gamblers when treating peri-implantitis. We are not sure if this is going to be the case that is going to work, if this is going to be the case in which I'm going to fail. However, we need to understand that dental implants are not the same than teeth. And there's many factors that can contribute to this heterogeneity. Of course, there are factors related to the baseline situation, how we define the case, which is the severity, the implant design, the surface, the prosthesis, the number of implants. There are also patient-related factors with different susceptibility, with different risk factors, that they collaborate in a different manner, that they perform hygiene in a different manner. And of course, there are treatment-related factors, protocol selection, how many times we perform the treatment, which is the follow-up, how frequent do we maintain the patients after the treatment of peri-implantitis. So this is the reason why the results remain highly heterogeneous. And of course, the next thing that we need to evaluate and to answer is if the reconstructive therapy is feasible and is predictable. And for this, I would like to welcome to the next speaker, Derks. This is my disclosure. I don't have any conflict of interest. Thank you very much for your kind attention. Muito obrigado pela atenção.
Ignacio, thank you very much for your outstanding presentation. Please take a seat next to us. Before we continue with our next presentation, I want to remind you that using EAO app, you can send the questions to our speakers. And also, this is a live session. So it means you can see our presentations on a YouTube channel, EAO channel. You can share this information with your friends and colleagues who cannot be here and still want to see the presentations. And now it's my great honor to present our second speaker, Derks. He will present us what is the current evidence regarding the efficacy of regenerative therapy of peri-implantitis. Jan is a specialist in periodontology. He's working in periodontology department at University of Gothenburg in Sweden. And also Jan is an author of a number highly cited scientific publications on the topic of peri-implantitis. We are very happy to have you here, and we are looking forward for your presentation.
Thank you, Aušra. Thank you very much. So, good morning, also from me. I want to echo your words, Ignacio. Of course, it's a great honor to share this session and to meet all of you here today. Esteemed colleagues, Ignacio, Frank, Aušra, thank you for your kind words. And of course, thank you to the EAO for the invitation to be here. It is my job now to extend on Ignacio's talk, where I will focus on the subcategory of what you presented, Ignacio, which is now the regenerative approach. I will pick up on some aspects that Ignacio has already mentioned, but I'll go a little bit deeper on what is a regenerative approach. Let me, before I start, also disclose any potential conflicts of interest. The research that I'm involved in is sponsored by the groups to the left. Myself, I'm employed by the university and a hospital setting, and I sometimes receive lecture fees from the industry. Our department has a grant, is also collaborating with industry. So that's about me. I would like to start setting, so to say, the stage with a clinical case. This is a patient that is involved in a trial at our department that I'll come back to later. And I think there's a couple of aspects that Ignacio has already touched on that you will recognize. We have clear clinical signs of inflammation, and you see to your lower right the recordings indicating, of course, together with the radiograph, the diagnosis of peri-implantitis. This is an aesthetic area, so I think what Ignacio has referred to is a key issue here is recession, which of course we want to avoid, soft tissue recession in the anterior. So in a perio setting, we immediately translate this to a reconstructive or regenerative approach. And that, of course, is very much the same at this particular site. So what I'll do now is I'll show to you our clinical protocol. And this, I think, is what we're going to see now in the next 30 minutes. I'll switch between what is very much an opinion and a protocol, and then I'll switch to what is maybe scientific evidence. And I'll try to be very clear on what is what. So please look at how we, in our hands, treat this kind of situation. Of course, it is very much the same that we expose the site exactly like Ignacio showed. What we will do is we will chip off any hard deposits on the implant. We'll clean, and that is purely saline. We don't use any other chemical agents. What we will use is a rotating titanium brush that you see on your lower right. And that pretty much is our protocol as it comes to decontamination. And I will add some scientific evidence as we go along. From a reconstructive point of view, we now, in this case, randomize her to the addition of a xenograft. This is a bone replacement graft as part of the reconstructive regenerative protocol. And I will now take you through the healing up to 12 months. We suture, we see her after 2 weeks, and I will quickly run you through the follow-up, and you see the maturation of the soft tissues up to 12 months. At this time point, we will evaluate. Now, from a recession point of view, at the implant site, there has been a minor change. In my mind, the recession has probably occurred a little bit lateral to it. But you will agree with me that on clinical inspection, this looks a lot better than it did initially. And if we then add the probe, and Ignacio has told you about the criteria that we apply, that is shallow probing and the absence of bleeding on probing, we are quite satisfied at this stage. I will add the comparison to baseline, and there has been a minor recession on the buccal. I think it is more pronounced on the central incisor. And now, of course, you were asking for the radiograph, which, and I already tell you now, to me is secondary, right? What is goal number one? That should be peri-implant health. Goal number two, I have already indicated, is an aesthetic result that the patient can live with. So I am already happy, but of course, I would also show you the radiograph. Again, it is secondary, and it will show you a degree of defect fill. Now, the title of my talk, the first word, was a regenerative procedure, which implies, in the periodontal world, new attachment, which at an implant implies re-osseointegration, which you sometimes can read being the primary goal of these kind of procedures. So my first point, kind of conclusion is, how do we assess re-osseointegration? You know, that, by definition, is a histological term. And the tools that we have in the clinic, they of course don't include histology. We have the probe and we have the radiograph, so we can't assess re-osseointegration. So with the permission of the chairman, the chairwoman, I will now change slightly the title of my talk, because I will focus on clinics, and then I will replace regenerative with reconstructive, because that's what we truly assess in everyday work, right? Reconstructive is histology. I don't really care what happens in my patients on a histological level. I assess clinics, and I may also assess a radiograph. Now, what I'll do, I'll pose some questions. We are now in a reconstructive setting, and you saw that I applied a bone replacement graft, a certain type, a xenograft. The question is any particular product superior to the other? And should I or should I not add a membrane? These are the questions I would like to address. And we are maybe getting ahead of ourselves a little bit, because before we do that, we have to decontaminate. And my question at this point is any method of decontamination superior? And let me be a little bit provocative. I'll already answer. And I will say, based on evidence, and this is now me critically reading the available evidence, no, there's no data supporting one or the other product that you may use. Should you now ask, what's the evidence on a membrane? Should we do that? If you read the papers carefully, there is no evidence supporting the use of a membrane. The final question, I will say yes. I will present some data that will indicate the superiority of a certain protocol over another, right? And this is me now being a little bit provocative, and I will try now to support my statements as we continue. I already showed you this reference, which comes from our group, where I will answer question 2 and 3. From a pre-clinical point of view, we have to be very clear, this is pre-clinical data. You are well aware of the scientific model that is used of inducing peri-implantitis in this preclinical model. It's a ligature technique where we induce defects that you have already seen that are maybe very much like the 1E type, the contained defect. The specifics of this particular experiment include now the use of 2 implants with a similar or the same geometry, but with a moderately rough surface, an assay value of roughly 1.4, which is considered moderately rough today. Implant type B, however, is a very smooth surface. It is an acid-etched surface with an assay value of 0.4, which is very smooth. We now treat, expose these sites, we clean, and then the sites will be treated in one of 4 ways. We have an empty control, we place two different types of bone replacement grafts, and to the right, you will see the addition of a membrane. So it already addresses these two questions from a preclinical point of view. I will show you now the radiographic results of this 6-month follow-up. I will start with the rough implant A. You see the clinical slides, the resolution, both radiographically and clinically, and the change of bone levels over time. And this, in part now, answers some of our questions. You will be surprised to see that the empty control is superior to the grafted sites. It's not exactly the same at implant B, but the combination of adding a membrane certainly didn't add anything at the at the smooth implants at this site. So I think one first conclusion, looking at this data, is that the combination did not appear to add anything. The empty controls did surprisingly well on the radiographs. What is, however, very clear is that there is an overall difference between the implants. So if I organize the data, you see that the most pronounced effect in this data set doesn't come from using one or the other material. It comes from the implant surface properties, where we do much better at the smoother site, the smooth implants. So I think, as we now tend to discuss very much technical issues, is it this material, is it that, we should maybe stop for a minute and we should go back to the basics. What is the real issue? Well, looking at this data set, it seems to be a matter of cleaning. Can we clean the site? So my last question, Ignacio addressed it, decontamination may be the most important question, much more important than anything else. But what is clear, preclinical data, is that the addition of a membrane did not add very much in this particular setting. We, of course, now looking at radiographs, we also have histology, which again addresses the re-osseointegration issue. If we here, first and foremost, look at the final bone levels, we confirm that the smooth implant shows better results, that is, higher bone levels, regardless of technique, consistent over any techniques. If we now add the re-osseointegration indicated by the fluorochrome marker, this is new contact on previously contaminated surfaces. This is a consistent finding at smooth sites. It's almost 100%, it's consistent. While it's a 50-50 situation at the moderately rough sites. If it occurs, it is very much the same amount. So it's a yes or no question. Basically, do we manage to clean sufficiently or not? And that question, again, appears to be very much related to the surface properties. So, based on preclinical data, you have already seen my answers to these two questions. I will shift a little bit, addressing both questions also from the clinical point of view. But I will add, before I do that, a sub-question that Ignacio has already addressed and I already started talking about. We agree on we have to clean, we have to resolve the inflammation. That is our basic goal. What now drives me to choose a reconstructive therapy as opposed to pocket elimination, resective approaches, right? And I already told you that if you go into the re-osseointegration question, that can't be a clinical driving force because we can never measure. So what is left? Well, you may look at the radiograph. I like radiographic bone fill, you may say, but basically nobody really cares about the radiograph. What do patients care about? And we already addressed that. That's soft tissue level. In other words, amount of recession. Can I prevent recession by adding a bone graft? That should be the basic question, right? And if you just look at this particular case, we apply the same technique, and at 1 year, we take this image, and let's say I achieve roughly 50–60% of radiographic bone fill. And that's pretty much what the research, the evidence will tell you. So I am in line with what has been published and shown. I will also tell you now that if I probe, and this is true, at 1 year, shallow probing and the absence of bleeding on probing, right? But does the patient care, right? I mean, he's happy that it's healthy. I'm happy about this, but the patient is very unhappy about this, right? And let me come back to this particular outcome, recession, as I look at the clinical data that is available, the clinical data. We were asked to summarize the evidence by Professor Schwarz at a recent workshop of exactly what we're talking about, which is reconstructive surgical therapy. How do you analyze? Well, what do we compare the addition of a graft to? Well, we look at the perio approach, and we compare it to open flap debridement. That should be the golden standard. Open flap debridement versus the addition of a graft. And what now are the crucial outcomes? I agree with you, the radiograph, the bone levels are important. Signs of inflammation are important. But what drives me using a graft, again, is recession and happy patient. So if we look at this, the availability of this data up to today, it's quite limited what you can find. What we're looking for are exactly these control studies. And you will find 3. And what do they tell us? Number 1 is inflammation. Does the addition of a graft or a biological agent reduce inflammation? Well, no. It is not superior over empty controls. What about recession? There is no data on this particular outcome. The one that I said drives me to choose this particular technique has not been documented up to today. And let me add a comment to that in a minute. The one difference that is documented is the radiographic, is the marginal bone level change, where the addition of a graft in 2 studies will result in this benefit expressed in millimeters. But that's a radiographic appearance, and I like it. But basically, I could ask myself, do I care? It is secondary. Now, I will add a couple of comments. There is one additional study published by Professor Stefan Rehnwert, who is here today, published after this systematic review. So it's not included. That study did address recession. Controls, or rather test sites, the addition of a graft did not improve soft tissue levels over controls. So there is now data available, not captured, but it is not really supporting the use of a graft. versus controls. I will add another comment. The materials used in the control trials available today are distinctly different from what is documented in observational research. The most used products have not been tested in control studies. There's an imbalance. So the conclusion that we drew from the data was that the amount of evidence is low when it comes to this particular question. The usually used, the most commonly used products in everyday and in observational studies is not what has been tested in control studies. And we are, of course, somewhat limited by the lack of evaluations of soft tissue levels and maybe also PROMs. So there's a need for future studies. And let me introduce to you an ongoing trial where the first patient was a part of, where we evaluate a graft, and of course we compare it to an open flap debridement, which is the empty control. The setup is, as you see here, we are looking at 12-month data of pronounced defects, where we prepare the patient, and then, of course, we do a reconstructive approach. And test and control are simply the addition of a xenograft. And the cleaning protocol you have already seen, and I'll show you a video in a moment, is very simple. We do add antibiotics in both groups, and that is exactly what Ignacio showed you, is based on 3-year data showing an additional benefit at modified designs. And now, the focus on the outcome is, of course, on inflammation, but it very much includes recession. So the hypothesis being that the addition of a xenograft will add benefit in terms of recession, that is, prevent recession. You know, 140 patients, that is nothing you can manage in one center. So this is a multi-center trial, and you see the colleagues involved, some of them also present here today. So it's Italy, Spain, Germany, and Sweden. Up to today, we have operated on 112 patients. So we are moving, it's close. This is the group, you will recognize some of these colleagues, that we meet for a calibration session that you, of course, have to do. And I challenge you now, and I ask you, is this a test or is this a control site? It's a reconstructive procedure, so it's a careful flap handling. We clean and we close. The question is, do we use a graft or not? Rather, did we use a graft or not? The answer is no. This is a control site. And I promise also that I did not switch the radiographs. This is baseline. This is 12 months. But basically, I repeat, I don't care about the radiograph very much. I mean, I like it, right? It's nice to show. But what is the crucial point? Number one is the absence of bleeding and shallow probing. That's number one for everything we do. And apparently, we also managed to avoid recession, at least pronounced recession. Right? So from a success point of view, this is obviously a successful case from the patient point of view. Now, I will grant you, this was a narrow defect, very favorable for this particular procedure. Right? And that is, of course, included in our assessments, but it proves that conceptually, reconstructive therapy is feasible at implants, and we'll have to see if the addition of a xenograft, a replacement graft, really adds anything. That is open for discussion, but it is a feasible approach in the treatment of peri-implantitis. So the final and maybe most important question, and I already told you, is there any superior method? Well, the method that we use is very simple. We clean, we chip off what we see, and then we will use a rotating brush that will pop up in a minute looking like this. And this is saline. That's it. And this is the protocol that is part of the study that I introduced to you. You see the amount of calculus that we sometimes detect. And of course, it can be a challenge to remove. So I see the attraction of using a machine-driven instrument and maybe of drilling threads, of performing a plastic. For us, we don't. We don't touch the implant in that way. So there, and we can certainly come back to that, we differ the protocols from Frankfurt, from Madrid. We don't perform implantoplasty. What we do is we chip, and I repeat myself, and then we use the brush. And now, if I come with an opinion, it feels very nice, right? The implant surfaces using this protocol, they feel and seem to be very clean from an inspection point of view, right? That was an opinion. I will move to data, and I will move back to preclinical data from my colleague Jay, together with Mariano Sanz and Nacho Sanz-Martin, is looking at in vitro data following cleaning procedures. And this, of course, is a model with 5 groups, and you will recognize these products. There are 2 titanium brushes, there is an abrasive technique, and we have ultrasonic metal scalers. Looking at them now in an electron microscope, it's the following that the authors that they find. Using metal scalers will pronouncedly damage the implant surface. Using a Teflon-coated ultrasonic will lead to debris remaining. The 2 brushes will flatten the peaks of the threads. They have an effect. The least, or the most conservative, was the air abrasive. The only technique reaching the valley between the threads are these 3. Here, we don't reach into the valley of the threads. So the conclusion is exactly as I read. Looking at in vitro data, we should probably focus on something towards the right. This is my interpretation of in vitro data. If we translate this into clinical research, and I will move now to the group of José Nat in Barcelona, who is also here at the Congress, he uses a reconstructive approach as a basic therapy and randomizes into a very basic approach, while in the test group, he adds a rotating titanium brush to the cleaning procedure, very much like a brush that you saw in the previous study. All patients otherwise receive the same reconstructive treatment approach. And the data is very clear. You look at the clinical outcome at 12 months, you see the reduction in probing pocket depth versus the control. It's basically double. And this goes for all the parameters. That is the reduction of inflammation and the radiographic bone fill. So with this, I use this data, in vitro data, clinical data, to support my conclusion of the question. Is today any clinical, any decontamination procedure superior to the other? Then I say yes, and it is something that we turn into the clinical procedure that you saw on the video that we use today. This is the conclusion as it reads from the authors. So I think that I have added some particulars on the aspect of reconstructive treatment to the basic understanding that Ignacio has given us as an overview. And with that, I thank you very much for your attention.
So please join us. So thank you for providing us. This is really the latest insights into the research projects that are going on. So thank you for this comprehensive review. I would like to thank you for sending so many questions so we can jump into the discussion. And maybe we start with a quite simple question. We have used, and you both have quoted it, that the 5 millimeter threshold is commonly used as part of the composite outcome for defining disease resolution or success of the treatment. So how does it come, 5 millimeter?
I mean, thresholds are always dangerous, and even more when we're dealing with implants, because nature has not given us implants, and proven pocket depth is going to be related, first of all, to soft tissue height and also to implant position. So we need to take these factors into consideration because the starting point may be a pocket depth of 6 millimeters that it's completely healthy because the implant was placed too apically. So, of course, thresholds need to be there in order to guide us, but they need also to be individualized.
Okay. Maybe we start with the wording. So, honestly, I was a little bit confused when you came with the reconstructive term. And, of course, the explanation is clear. You consider the osseointegration, but we are using augmentative, regenerative approaches also to identify clinical outcomes. So it does not necessarily mean that we just look at the histological level. So would you still be fine with the term regenerative, or are you really strict?
Yeah, of course this is it's a semantics, a matter of semantics, but I think it helps us to maybe not be too confused, because I think if we put a goal for our treatment, it has to be something that we actually can assess, right? Did I reach my goal? Yes or no? And if then a term as re-osseointegration is put forward as a reasonable goal, I mean, then from a clinical point of view, it makes no sense to me, right? So that's why I think I pushed a little bit, but I think we all agree, and then it becomes a matter of semantics. So of course, I agree with using the word regeneration, right? But I think it comes very much from the perio field, where we have exactly the same discussion, of course.
So what we both like to achieve is to give at least some indications for the protocols that we have discussed. But before we jump into this issue, Ignacio, you have touched a very important point. So when it comes to the prevention of the disease, we are still struggling with the need of having keratinized tissue, or not about the amount, but the same applies to starting the treatment per se. That means when we look at this case, a complete absence of keratinized tissue, this is right after a non-surgical treatment. So the next step would be, still in the presence of BOP, to proceed with the surgical approach. So what would you recommend before you start, let's say, with a regenerative approach or reconstructive approach? Would you start to establish keratinized tissue? So what might be the message to the clinicians?
So I think that the first thing that we need to evaluate is how bone loss has occurred, which are the main contributing factors to this bone loss. And of course, if we expected that, or we think that a keratinized mucosa has been a problem in this patient, especially in relation to pain during brushing or to troubles, of course, we're going to augment it. The question is if we're going to do it before, during, after. So we don't have an answer, because at the end, the literature, it's really scarce. what I know, and it's also based on some of our clinical experience since we are running a study, is that we are doing these cases together with the surgery to treat peri-implantitis when we're dealing with resective approaches, okay? Because for us, it's very easy to combine the management of the soft tissue. This means we get access very easily with full thickness flap just to the most coronal portion of the implant, and then it's very easy to apply a split thickness flap to apically shoot the flap and to use a graft.
But my point here is rather the question, when we look at the next slide, and I hope it comes. Yeah, sorry. So when we compare the situation here and this, sorry. So the situation here and here. So if this would be the starting point for a reconstructive approach, which situation would you prefer? So to cover the graft, to cover the material?
That's an easy question to answer. I mean, this is, of course, a dream to handle from a surgical point of view and from a patient point of view. So I would prefer this situation. I think, to answer to the same question, should we then routinely go through this before we then address the peri-implantitis issue?
That's a question.
That's the question, right? I would say I would hesitate at this stage, and I would make it very much dependent on the patient's ability to perform infection control. If there is pain leading to inability to perform, then yes. If not, then the data today, I don't think is sufficient to routinely recommend this procedure as a, so to say, initial approach. So I think it has to be a case-to-case decision, probably based on the patient's ability to perform the cleaning. That would be my, so to say, official answer.
And that also raises the question on the approach. So you have, Ignacio, shown one case where you have submerged the site, whereas in your multi-center trial, you go for a transmucosal healing, which is, in essence, the most commonly used procedure in the available studies. So how do you decide it? When do you submerge and when do you go for an open healing?
Yeah, that's a very good question, because you did a study in animals. Ramanauskaité has also done a case series, and the results are very scarce. What we need to bear in mind is that, as we have seen, most of the implant defects are combined defects in which we have already a portion of supracrestal component. This means that we are not going to have support for the graft or for the membrane, so the pressure at that level in the soft tissues is going to be high, and in most of the cases we are going to have early exposition of the soft tissue. So if at the end I have placed a cover screw, wait for a soft tissue coverage, and I'm going to have an early exposition, I think it's not reasonable to use it. So I'll go for this type of procedures when we have a pure intrabony defect, or without any supracrestal component.
Then you go for a submerged healing?
Yes.
Okay. That's a decision tree, that's clear. Yes. But honestly, when we look at the literature, we have high exposure rates when we submerge the site, and we always have the problem with a provisional prosthesis, which may also compromise the healing. So it is still common sense that transmucosal healing might be the preferable way.
We basically never submerge. So I think we differ also in this aspect. To us, it's rarely or never part of the protocol. I mean, for the obvious reasons that you said, the temporary solution. So I think we have to, the challenge to us is to find the ideal protocol that includes transmucosal healing.
Okay.
I think
let's have a look at the next component. Aušra.
Now I'm moving to another slide, and I would like to address the question to both of our speakers. Yes. So in cases of peri-implantitis, we have so many different bone defect configurations. And I would like to ask, do we have like a gold standard treatment protocol which is applicable in all of the cases? And how important is the defect configuration once you choose which treatment approach to go, for which treatment approach to go? Jan, maybe.
Shall I start? You know, to take a very basic answer, does it matter, so to say, for treatment outcomes? Then I think it's somewhat ambiguous. Now, Frank, you have to correct me, but I think your data shows that it does matter, just in simple terms of disease resolution, while Mario Rocuzzo's data would indicate maybe not so much. Now, there may be differences in general, but if we go back to the perio literature, I think it very much makes sense that, of course, it matters. Specifically, if we look at the reconstructive potential, I mean, if I look at your implant, the upper row, the second from the left, now, what is the reconstructive potential of a completely open defect lacking buccal and palatal plate? I mean, that must be extremely limited, right? While I see some more contained defects where I would be much more positive on the reconstructive approach. So I would say, and this is without data to me, it matters very much, and we are recording it very carefully in the trials to evaluate. And I think today, from a clinical point of view, as we see our patients, it has to be part of the decision tree. So in the one that I'm referring to on the upper, I would look at a resective procedure if I can get away with it from an aesthetic point of view. Placing a graft, placing membranes, which we don't do, placing a graft, I think will add very little. That I put on my perio data where I have one wall defects, right? 2 of them.
Yeah.
What's the potential? So, but this is translating data from perio into peri-implantitis, which we don't have, right?
Yeah, but also considering a matter of fact, which is biology of bone regeneration.
It's plausible, right?
Yeah.
I mean, yeah.
The more supporting walls, the better the outcome. Ignacio, would you also support this statement?
Yes, and I've shown it in the presentation in our decision-making tree that the type of defect and defect configuration may clearly guide us on which type of procedure. I think that during many years we have tried to reconstruct, regenerate every type of defects, and this is one of the reasons why the results have been not that good as we would like, and it's because very few defects are the real candidates to be regenerated or reconstructed, so we need to take that into account when dealing with the treatment.
So we should mainly focus on contained defects when selecting reconstructive protocols.
You know, I mean, that would be the ideal. However, I think we have to take in what are the patient's wishes. And if I now interpret that picture correctly, that looks like an upper anterior case. So I think a resective pocket elimination approach is not really on the table for most patients, right? So we may very well try anyway with the data we have today, because the alternative is simply not accepted by the patient. Then we have to move the whole treatment to another direction, which is maybe removal and something else, right? But of course, I think the ideal in the end is a decision tree that includes defect geometry.
Okay. I guess there is a common sense.
I think so.
Another point that is of utmost importance that's clear is definitely the outcome in terms of mucosal recessions. And you have presented many cases, so the patient is really unhappy when that's the outcome of the treatment. So at least in the aesthetic zone, we may have to rethink about the protocol. So how can we avoid it? You have mentioned, I'm a little bit surprised, that by applying a bone filler, you can counteract the mucosal recession.
That is the hypothesis.
Hypothesis,
right?
yeah.
I think today's data would so far not support that statement, right?
Exactly.
So it remains to be seen. And I think these are exactly the type of cases, the one in the upper row, where that would be then feasible. If I look at the lower premolar, that may be less of an issue, right? Do I have 1 or 2 millimeters recession? But for sure in the aesthetic area, that is the big question. And would or does the graft help? Right?
Yeah. What would be your choice, the protocol for the aesthetic zone?
Good answer. I think it depends. Again, I'm going to get back to the type of defect and the type of procedure. And of course, also take into consideration the patient, the smile line. So if there is an aesthetic risk, and I think that with my treatment, I'm going to be able to arrest disease, of course, I would try to compensate recession with a connective tissue graft. The problem is that if after my treatment, that implant is going to remain with residual pockets with high chances of being recolonized, I don't really see the impact of placing a connective tissue graft, since I'm going to know that reinfection may occur. So in these cases, in which reconstructive is not feasible, and in a case in which the patient has very high aesthetic demands, I may consider to extract the implant.
To
Extract the implant.
Okay. This is also an approach, but in terms of protocol of keeping the implant, what would you prefer? So you have touched the connective tissue graft, which may be a potential aspect.
So if the implant is in a high risk of being recolonized, I would just go for treatment, place a connective tissue graft, and place the patient under very strict maintenance protocol.
You have briefly touched the outcomes of the European workshop last year, and one point that we have addressed in the recommendations for future research is, of course, to define a composite outcome in the evaluation of a reconstructive approach. But when we take a look at this requirement, and Stefan was here, maybe he left, but that was taken out of his paper as an example. So when we look at the details, we have to obtain more than 1 millimeter radiographic defect field, which may be achievable. We have to reduce the PD below 5%. Mucosal recessions below 1 millimeter, and no suppuration and no bleeding. So, my God, this is almost impossible to achieve when we take all the things together. So,
I'm glad you touched on it, and I think this is a good time to comment on. In my mind, these are recommendations for scientific evaluations, where we then come up with a percentage of successful, non-successful. If I should evaluate my treatment in a clinical setting in one particular patient, I don't think any of us should think in this way. Right? We make very individual assessments. So what if I have a 6 millimeter probing, based on anatomic that you touched on? I mean, do I then kind of call this case a failure just based on that? I mean, of course not. I have to use a common sense and follow up my patients in a reasonable way. And these are composite criteria for scientific evaluation. I think we should remember that. What if I achieve a shallow probing? I'm happy with my recession. I am happy with the clinical measures of inflammation, but I do not achieve the defect fill in the radiograph. Who cares?
exactly.
Right? I mean, then, it doesn't matter.
So when I got it right, so the first and the most important aspect is no separation, reduction in BOP, maintenance of, or to limit the mucosal recessions and keeping the bone level stable. So this might be the recommendation for our daily work for the practitioner.
Right.
That's right?
I completely concur.
Okay.
Yes, and if you can have it also with no pockets, that's great.
Yeah. Okay.
So I guess we are out of time.
Exactly.
Dear colleagues, I feel that you will be more secure on Monday if you have a case of peri-implantitis. Thank you very much for the speakers. Thank you for sharing your time with us, and enjoy the remaining sessions that are still waiting for you.
Good.
Thank you.
Thank you, Frank.
Welcome back here in our EAO channel live studio, live from the EAO Congress 2019 in Lisbon. Stay tuned, stay with us, because our speakers Ignacio Sanchez and Derks are currently on their way from the auditorium to join us here in the studio. And us is me, myself, and Kasia Guzawaska, who has been watching the session together with me. Hello, welcome back, glad you're still with us. And you, of course, and you can use the feature of our live chat to send in your question. And I see Ahmad Korkmaz, glad you're with us, you're doing that. Renato Colucci is doing that. So if you're still with us, please stay tuned, send in any questions that you have related to the topic of how to treat implantitis in general, or anything that you've just seen on stage. And we'll do a 30-minute debrief with our speakers here in the studio, exclusively for you. Now, to bridge the gap for our speakers to come down a little bit, Kasia, this was a very exciting morning for you, because even during the first part of the session, you had to run away and present your own research paper in a poster session.
Yes, the topic was a bit different from what we heard today during the session. It was about digital dentistry, that is an enlarging topic and fast growing. So I think the presentation went very well, and all the audience had a lot of questions, so I kind of wanted to move from the room, but didn't. So it's also a nice topic to watch as well.
Yeah, because you're a researcher from the University of Birmingham, and you're currently also working on a very exciting project related to the field of peri-implantitis. Can you elaborate a little bit on what your current research is about?
What we saw today, the peri-implantitis topic and the treatment is very challenging. And I believe that there are other methods to prevent the peri-implantitis to happen. So I'm working on the biological aspect and the modification of the implant surface on the molecular and nano level. So we are introducing the plant-derived nanoparticles into the surface, into the smooth surface of the implant, in order to attract the bone cells to have a successful osteointegration, but at the same time reduce inflammation process in the later stage. So it's an exciting study, and we are still in the preclinical state, but hopefully in a couple of years we'll hear more about it.
So you say it's a plant-based derivative, so it's something you found in nature that should improve the histology. One of the things that we heard Derks talk a lot about is that in the clinical practice, we don't look at histology. He kept going on about it. There's only two things that matter. It's the patient-perceived soft tissue level, that's all they care about, and we only have radiography, so we look at bone level. So I can imagine it's quite difficult to bring your research findings to the clinic. How do you intend to do that?
So it is a quite long process to understand, and it's a part of my specialty as well as an oral surgeon. We need to analyze the histopathological reports and slices. So it is a bit of a process to learn, of course, but therefore we are here to listen from scientists and researchers who spend the time to analyze the histology, also do all the experiments that Jan presented in vitro and in vivo, in order to bring the knowledge to the clinic to apply it. And it's very important to continue in this stage, because we will in some point reach some statement how to treat peri-implantitis. I hope so. After today, I'm very optimistic to hear that they brought so successful results. However, I still think that there is a lot to do in the prevention part of the implantology. So therefore, I'm concentrating on bringing something new to the clinic, working with stem cells and understanding the mechanism in order to direct and have the more customized way of therapy for peri-implantitis.
Exactly. Now, if you're just joining us, we are live here downstairs in the lunch break at the 2019 EAO Congress, where international professionals in the field of implant dentistry gather from all over the world to meet and be inspired and educated about the future of implant dentistry. And we're very proud and honored that you're with us here live this morning as well, or perhaps you're watching this session in recording. And in the meantime, our speakers that you just saw on stage are coming downstairs. And if you haven't seen the session from the start, we started off with Ignacio Sanchez, who gave us an overview of the current approaches in treating peri-implantitis, and he showed basically 3 different approaches. He talked about implantoplasty, which is basically grinding down the implant to prevent any contamination to stick around. He talked about the antimicrobial approach and a combination of the two, and he talked about his third approach, which was more surgical, and then he handed over to Jan Derks. And then Jan Derks went on about the regenerative approaches. What can we do to restore bone level? What can we do to restore soft tissue? And he really tried to found his findings in science and showed us an overview about what is scientifically proven and not. Kasia, when you were listening to Jan, what struck you about his story?
Well, I think Jan stressed a very important aspect of dental implantology. The surface of the dental implants, it's a major factor that influences the osseointegration. And if we remove the surface, we modify it, of course, we also automatically change the osseointegration process. So we need to remember about the two relations. So Jan was pointing out that we should actually not touch the surface, and I am looking forward to asking a question about what he thinks about the gold standard surface. Should we come back to the smooth implants, because we see that they also integrated, but then the biofilm, it's not so accumulated in the smooth surface as on moderate surface that is rough.
And just to be super clear for perhaps younger dentists or general audiences finding this video, we can talk about surface in different stages of the implant, right? We have the bone level, we have the abutment, and we have the prosthetic or the crown. Where are we talking about? Because we saw the implantoplasty where we're literally grinding the abutment, right? So when we talk about surface, which part of the implant are we talking about?
We are talking about the exposed part of the implant, exactly. Because we lost the bone and we have the access to clean it. So regardless whether that's on the implant level or the abutment, it has to be about the exposed yes, the exposed part. So it's very clear for us where is the infection and inflammation, because there is debris on the dental implant, there is biofilm that we can't see, but then you can see the plaque accumulation. So all of it has to be clean. And then we heard a lot about the methodology and how to make the decision about the different approach, non-surgical and surgical. So I think Jan and Nacho, they are experts in this field. Definitely for dentists, general dentists, it's very important to access the exposed implant screw. And sometimes it's very challenging when we have retaining implant dentures to remove it. If we don't have a screw retained denture, we can't remove. It's quite challenging. So the access is the key. That's why Ignacio told about the surgical approach. where we can actually clean it very well with this surgical approach.
Exactly, very clear. Well, if you're just joining us, or if you're still joining us, this is the moment where we're always most excited about because Ignacio, Sanchez and Derks have made their way from the auditorium here downstairs to the lunch break area. Gentlemen, please walk up because this is the time for your exclusive Q&A with our two speakers. Take the opportunity, send in your questions. Gentlemen, congratulations on the great session.
Thanks.
Very interesting, and glad you're with us here this morning. Luckily, I have Kasia on my side as my expert co-host. So Kasia, you've been following the session. What would be your first question you'd like to ask to these gentlemen?
So first of all, it was an exciting session, thank you. I learned a lot as well. And I have a question to Jan, because he mentioned in the end of the presentation that in your institution you don't actually touch the surface and you want to actually prevent from any interaction with implantoplasty. Why is that, and what do you think? What is rational about it, and why the surface is so important to not modify from the point of view of osseointegration?
Well, thank you for that question, and I think it's a very crucial point. You know, of course, we touch the implant. To be very clear, we decontaminate. Where we may differ, the protocols, is that we do not purposely change the geometry of the implant, that is drilling away the threads. Mm-hmm. This is something we don't do. The reason simply being that we, for one, do not want to spread particles in the surgical wound. That may be considered number one. We generate heat, and we don't want to do that. We may structurally weaken the implant, and then maybe finally, the implant surface that you create, even though you may polish, may microscopically be very rough. Mm-hmm. So this taken together is the reason, or the reasons why we today do not change the geometry of the implant.
Well, three very strong arguments. Ignacio, I'm just wondering, how are you feeling when you hear this? Because you presented this as your first option of treatment.
You know, we're always having this kind of struggling and battle of concepts. However, trying to counteract what Jan has said, we try to protect the wound with a lot of gauzes, with a lot of suction. We use later on air polishing systems, trying to minimize the amount of residual powder. We also try to give extra irrigation, not only the irrigation from the turbine, but also a lot of saline.
Reason being to cool down?
To cool down.
Heat reduction, yeah.
And of course, it's a matter of time, and we need to be, we can't be in a rush, okay, when doing implantoplasty, because it has been shown that we can end up with a smooth surface, but we need to employ a lot of time. And different protocols have been proposed showing that you can reach the smooth surface. However, there are other factors that we need to take into consideration. Implant location, the patient. It's a difficult technique, so there.
But Ignacio, are you not worried about the microscopic roughness of the thing you leave behind that Jan is pointing at?
Yes, of course, I'm worried about it. But I'm also worried on leaving exposed threads, okay? Because, of course, there is a supramucosal portion that it's going to be very difficult to clean by the patient. But what I do like from implantoplasty, beside all the limitation that it has, is that when the patient comes to my clinic to maintain it, it's very easy for me to clean the remaining surface. Although I know that I may not ended up with a smooth surface, although I'm assuming that that implant may fracture in the future. But this is the white and black thing, so
So I guess the takeaway from both of your lectures, because Jan, you showed us some research into what is the best decontamination method, that if you have grinded, then at least use the airbrushed or the titanium brush methods to clean later, so you clean on a microscopic level as well.
You know, and let me just add that, you know, this is a matter of controversy, you know, and not just between us. I think there are many groups that simply don't agree, which is completely fine. That's where the research is today. And you know, I would also like to acknowledge that it sometimes is very attractive to remove that part, the threaded part. You know, we ask a lot of our patients to maintain exposed threads, so it is a challenge. So I think we are maybe not so far apart as it as
But
it
you
may
let
seem.
the disadvantages prevail for now.
For now.
Because you, at least in this talk today, you showed I'd rather regenerate either hard or soft tissue. Well, there's actually a question about that. And if you're just joining us, we're live at the EAO Congress. And since we're live, you can send in your questions and we will ask them to our speakers. And this is Tel van den Berg. Sounds like a Dutch name, so good morning to you. And he has a question for you, Ignacio. He says, if you remove the implant, you showed the decision tree that if more than 2/3 is exposed or more than 7 millimeters exposed, you go for extraction. When do you regenerate the ridge? Immediately after extraction or later, or what is your protocol there?
The first thing that we need to do before removing the implant is to carefully analyze which could have been the factors that have caused peri-implantitis. Once we know those factors, or we suspect from those factors, we really need to take care that in the future those factors are not going to occur again, or are not going to be present again. So in this sense, normally we never regenerate at the same time, because we need to realize that that was an infected site, and we know that based on many studies that have been performed in Göteborg, that the infiltrate and the infected tissue, it extends greater as compared to teeth, so it's not the same than removing a tooth. So normally we wait. And
So you leave it open and then natural healing occurs? How long do you wait?
so it depends on if we have factors that we are not going to be able to control, we may end up with the decision that we are not going to place implants again.
At all?
At all, so we may don't need to reconstruct. If we are going to reconstruct because we know that we can control those factors, of course we're going to wait for soft tissue healing, and this is going to occur between 6 and 8 weeks. Okay, so then we can move forward.
Exactly. Interesting. Thank you very much, Tel, for sending in that question. Earlier, and this was actually during your talk, Jan, we also had some questions, and I'd like to throw those at you. It's from Ahmad Korkmaz to start with. And to be clear, you already said on stage, we have science and we have my opinion. I think both of them are asking for your opinion. Ahmad is asking, do you prefer, there we are, local antibiotic or antimicrobial gel treatment around the infected implant?
You know, today we don't use any local antiseptics or antimicrobials as part of our surgery. So,
but you did mention you use antibiotics in the procedure, right?
As a systemic application.
Okay.
So that's what we do. In the majority of cases, and I think that's very much in line with what Ignacio showed, from a local application, let's say an irrigation or an application of a gel, we don't use any of that. So it's a simple answer.
The answer is I don't prefer any of the two because I don't do that at all.
That's the case.
Clear.
Exactly.
Another question that came from Renato Colucci. Renato, I hope you're still watching about an hour later, I see. What is your opinion on using bioactive glass instead of other bovine grafts due to their antibacterial effects? You already showed scientifically there is no better product, but what is your opinion?
Now, if I start with my opinion, it's also an easy answer because I have no experience of these particular products in this field. So I have to move to science, and then you already heard my answer. There's no data, you know, pointing to any one of these.
Exactly.
So it's the easy answer.
That's
we
the
don't
short
know,
answer.
and I have no opinion.
Let's have a look at Ignacio. Kazi, do you have any experience with these new materials?
So yes, bioglass unfortunately presented based on the study we've done recently that even though it has anti-inflammatory properties, it's not performing as good as BIOS regarding the bone regeneration, the progress of it. I think there are more studies upcoming in order to bring more data, as Jan mentioned. I actually would like to continue the topic of antimicrobial properties, as one of the outcomes from the Delphi study that we saw during the EAO is that more surfaces with antimicrobial properties will be developed in order to prevent peri-implantitis. And also we heard during the welcoming lecture about the stem cell technology. I would like to ask you what is your opinion about it, and do you think that this is the future of prevention of peri-implantitis?
Please, Ignacio.
I will answer you the question in regards to the implant surface. We know that the companies and industry is trying to develop new surfaces, not only bioactive surfaces that enhance and promote osseointegration, but also surfaces that once exposed have antibacterial properties, like for example, adding silver particles or something that we know that they have potential to be against bacteria. But I think that today we are far away from that. I think that the surface has something to do, but what we need to do is to prevent surface exposure. Mm-hmm. So we need to place all our efforts to take into consideration all the factors that may influence early bone remodeling in order to have a starting point in which all our implant is surrounded by bone, irrespectively of the type of surface. And this means surgical consideration, prosthetic considerations, patient considerations. So by controlling all these factors, our starting point is going to be a nice implant surrounded by a nice amount of bone. I think that's the most crucial point.
And you're saying in that context, where all those factors are okay, then yes, maybe bioactivated surfaces might also aid to the formula.
I hope so.
But you say it's not going to replace a poorly placed implant or other...
Yeah, what we would like, if exposed, because we have not been able to control all those factors, I would like to have a surface that has antimicrobial properties, but today we don't have that surface. What are the companies doing? We are coming back to hybrid implants, or implants that in the most coronal portion, they have a smoother surface in order to compensate that early bone remodeling that may occur. And if it occurs, that's going to be in a machined surface and not in a rough surface. But that's where we are.
In general, and let me quickly make a shout out to Lana. Lana, I've seen your question, I'm going to take it in a moment, but let's focus on the topic of surfaces a little bit. You referred to the Delphi study. If you haven't picked it up, this study was presented here at the EAO Congress. Over 130 experts have been interviewed, and then in the 3 phases, over 50 experts contributed. And specifically on the topic of rough versus smooth surfaces, the outcome is there is no consensus. So the world, the international community of implant dentists seem to be divided. Well, I also get the sense rough surfaces is something from the past and we should only go for smooth. Where do you two stand in this question?
Well, I think that we come from a little bit of special world, which is the peri-implantitis world. And I think both of us have shown the data when it comes to handling peri-implantitis. Then we would very much prefer a surface that is less complex, maybe not as rough. And to me, that is the more immediate future. That is the next step. I think in my mind, we'll go back in terms of roughness and complexity, and that's pretty close. Maybe 2 or 3 steps ahead are the bioactive surfaces. That's further away. But I think that the industry will pretty soon provide us with a choice as a clinician, so that we may, for a risk patient, choose a specific surface and may that surface may be smoother, already anticipating potential problems down the road. Much more easily handled, and that is a consistent finding in all research.
Yeah, so to understand this debate very clearly, Kajsa, maybe you can elaborate. If we say from a peri-implantitis treatment protocol we prefer smooth, then why is the world so divided? What are arguments to go for rough then?
So at the moment, the statement is that we recommend to use moderate rough surface because it promotes osseointegration.
Exactly. So it's more a mechanical
attachment, but also it's important for the cells to attach. So it's from both sides, molecular and biological. However, we know from your beautiful studies that they also attract bacteria. The biofilm is very complex and it's very difficult to remove and kill the bacteria because we have number of antibiotics and we have also to remember about the resistance. So therefore, my direction, of course, is to prevent it from happening. And I hope what Ignacio and Jan mentioned, that the companies are working on new surfaces, maybe new protocols for treatment, regeneration treatment. So we will see what happens in the future.
Exactly. Well, if you're just joining us, we are live from the EAO Congress and we're taking questions and they're coming in. Tal, thank you for your second question. But first I want to go to Lana. This is a place where the international professionals in implant dentistry meet. But on day 3, we also invite all the assistants, the oral hygienists and all the other people in the practice to come to this conference. And Lana L is actually asking, what would be your advice for a dental hygienist coming across peri-implantitis and treating peri-implantitis? Is there anything they can already do when they come across a case like that?
I take this one. You know, I mean, it's a very relevant question. And unfortunately, I think from the profession of a dental hygienist, this is a very frustrating problem because the answer is pretty straightforward. You simply can't do very much as soon as it is a rather established peri-implantitis.
Beyond what you're already doing,
exactly.
Which is cleaning the sites very well and maintaining.
You manage, maybe you can improve things slightly, but what will be required in the majority of cases is a surgical approach. So these repeated efforts, non-surgical efforts, are often in vain. They don't work. So I think my advice, if there is an established peri-implantitis, as a dental hygienist, you do it once, you treat it, you evaluate pretty quickly. If it doesn't work, you go ahead with the surgery. Right? There's no point in going around and around. That is very much the approach that we have in our clinic. So it's a frustrating situation for the dental hygienist.
Yeah. Ignacio, you pointed out on stage that we should try as much pre-surgical attempts as we can. What is your take to this question?
Yeah, of course we need to try non-surgical. First of all, because with a starting point in which we have a lot of inflammation, we cannot manage soft tissues by means of surgery. That would be a disaster. So we have to try it. Sometimes it may work, many times it's not going to work. But I mean, hygienists are essential in the equation. Maybe, as Jan has said, not at the beginning, but they're essential later on. And the only chance that this works in the long term is if the patient collaborates and if the hygienists do their work. So I think they're crucial in the equation.
Great, they're crucial. Lana, thank you very much for your question, and make sure that you send the link to this video to anyone who might be interested. It is on YouTube, it will stay on YouTube, so if you haven't done so, subscribe to the EAO channel. There's another question from Tal van den Berg, and Jan, I think he might have missed part of your talk, so this might be a little bit repetitive, but he's asking, what do you think of the titanium brush for decontamination of the surface and to remove the surface roughness? And you showed in your talk actually a comparison of different decontamination methods.
Exactly, and I think we just have to clear up some issues. Removing surface roughness is not really, as we already discussed, a goal per se.
That's not the way how you go.
So we are simply aiming at removing biofilm, and as part of this protocol, we believe that a rotating brush, as today, is a very powerful tool, and we have data from Spain, from Barcelona to support this. I'm sure that there are developments coming, but as of today, we have the brush as part of our protocol. But let me repeat, it's not meant to polish, it is meant as a
purely to decontaminate.
Exactly.
Decontaminate, yes.
Exactly.
Clear, clear. Thank you very much, Tal, for that question. Ignacio, the thing I wrote down when I saw your talk, when you report to disease resolution outcomes, your figures go up to 79, 80%. Can we be satisfied with that? And how can we reach that last 20% to actually really get a hold of this disease?
We would really like to have an 80% of disease resolution.
Yeah, that's already, we should be really happy with the 80%.
Yeah, but we're still far away. And these disease resolution rates have been shown mainly when we treat machine implants, not rough implants. So we would like to be there. The problem is that we come from a field that is the field of periodontal diseases, in which we know that if we perform a proper treatment and the patient comes to maintenance, everything works in the long term. And we're able to maintain more than 90% of the teeth even after periods of 25, 30 years. However, we need to understand that teeth and implants are not the same. Implants are screws. The chances of the implant to fight against the biofilm are much less than in a tooth. So we're far away from 80%. I think we would love to have 80% of disease resolution rates.
You know, that would be a very positive number, which we probably don't reach today. But I mean, also adding to the fact that these are very tough criteria that were set up for research. I mean, that does not necessarily mean that the case is a failure, right? So you would have to look at a little bit more from a clinical perspective, and the number is better than that. I think we today feel quite comfortable in performing and treating peri-implantitis cases. We have failures, as we have in perio as well, but we know pretty well how to handle most of the situations.
Okay. However, Kasia, we started off with that. We don't exactly understand how the thing works. Now, to round up, final question. If we meet again at the future EAO Congress, what do you hope, if you had a magic wand, what is your wish that we by then have figured out about how to treat peri-implantitis?
I would like to understand more the mechanism, because
the biological
mechanism about peri-implantitis, because there is still the etiology. There are question marks in this topic, so we know that it's due to the infection by bacteria that cause inflammation. However, the implant, it's the foreign body as well. So what is the relation between the interaction of our body into the titanium implant? It's biocompatible. However, in this complex situation, I think we need more understanding.
How it works on the molecular level, yes. And for you, Ignacio, what do you hope in the next congresses we can show? And
my wish would be that we have implemented all around the world primary prevention strategies. So what I would like to say to you in 5-10 years is that we have been able to reduce the incidence of peri-implantitis.
Yeah, by preventive strategies, basically. Yeah, and for you, Jan?
Yeah, I just echo your words, right? It's not so much the treatment we will improve, but most preferably we will have less problems, and that starts with primary prevention.
Exactly. Well, great wishes. Let's hope we meet again here at the EAO channel and we can talk about that. Jan Derks from Sweden, thank you. Ignacio Sanchez from Spain and Kasia Gurzawaska from the UK. And to you, if you haven't done so, hit the subscribe button right now so you'll be part of the EAO community online from now into the far future. You'll be the first to know when a new live video will start or when a new video is published. And we hope that you share this video to anyone who might be interested into the future of treating peri-implantitis. And then we can just say, from all of us here in Lisbon, we hope to meet you again at one of our future conferences.